Assalamu alaikum dear doctors. In this video I am sharing about the chest pain history, evaluation, management, differential diagnosis, all things. So chest pain history introduction is like all the history similar. Then present history and systemic review, what we ask. First OCD, that is onset, course and duration of the chest pain and any aggravating factor or relieving factor of the chest pain. Then we will ask that please describe for me the pain. Is the pain is associated with any heaviness or crushing in nature? Then we ask about the site and severity of pain. Is it associated with sweating, nausea or pallor? And is it radiates and where and any triggers? So radiation of chest pain, we know we can exclude the differential diagnosis. If the chest pain is radiating to the jaw or left arm, then that is myocardial ischemia. If the chest pain radiating to the left shoulder tip, that is pericarditis. If the chest pain associated with palpitations, then that is pathological arrhythmia like supraventricular tachycardia, frequent ventricular ectopic and ventricular tachycardia. And if the chest pain associated with syncope, then it can be pathological arrhythmia or left heart obstruction, severe aortic stenosis and hypertrophic obstructive cardiomyopathy when associated with syncope. Now, chest pain is superficial reproducible chest wall tenderness, that is musculoskeletal pain. If the chest pain is associated with exercise, that is also myocardial ischemia. If the chest pain is worse with movement or deep breathing, that is musculoskeletal. The chest pain is associated with cough and wheeze, that is respiratory causes. If the chest pain with eating or posture, then that is gastrointestinal causes. If the chest pain anxiety trigger hyperventilation, that is psychogenic. So first time or recurrent, is it reducible, how is stopped and for how long it is lasting. Any other pain at other body sites like chronic fatigue syndrome associated with. We will ask on the history about FWASL. FWASL mnemonic, we know that is fever, any weight loss or weight gain, and activity, sleep, and any lymph nodes. Now, any recent chest trauma or prolonged recumbency. Any other concern, any chronic conditions associated with the chest pain or not, we will ask. Then the systemic review will ask like CVS, the awareness of the heartbeats, fainting, any bluish discoloration of the lips, any swelling in the eyes, how many pillows using for sleep, sweating or interruption of the feeding baby. Musculoskeletal, we ask about any skin spots, any swelling, any lumps, hair and nail, there is pain of the muscle or bone or joint or any recent fracture, bluish discoloration of the gums or nails. CNS will ask about any headache, weakness, numbness, abnormal movement or any abnormal walk or behavior, any concern about vision, hearing or speech. From chest, we will ask coughs and colds associated with or not, any nasal discharge, any chest pain, that is recent bugs or chest trauma, any runny nose. GIT will ask tummy size, tummy pain, throwing up or oral soreness and lip cracks, anal soreness, yellow eye. For urinary, we will ask about P, the recurrent bug like pain, color, dipstick if done, bedwetting, blood pressures, frothy and amount. From endocrine, we will ask about the thyroid, any hot intolerance or cold intolerance, then diabetes mellitus, diabetes insipidus, we will rule out by asking the P. Hematology will ask about the pallor, bleeding, bruising and recent bug. Now we go for the past history, that is very important. We know the mnemonic 5T IOA. So 5T is that any trauma history previous, any treatment, which team is involved, and any blood transfusion history and any traveling history. IOA, that is investigation, onset and admissions of past. So we'll ask associated with the chest pain, any past history of asthma, acid reflux, sickle cell disease, Kawasaki disease, known congenital heart disease, previous cardiac interventions or surgery in the past 2 weeks, read any fractures present or not. So that is read that in the past 2 weeks any surgery present or not. Drugs, we will ask about recreational substance like cocaine, oral contraceptive pill drugs induce long QT syndrome. We will ask about this drug. Now family and home, that is very important. We ask about any consanguinity presence or not, conduction disorder or arrhythmia, long QT syndrome, then Brugada syndrome, these are associated with family history. Cardiomyopathy, sudden death in young relatives, age less than 40, present or not, we'll ask. Any connective tissue disorder, we'll ask. Then perinatal plus minus puberty, vaccination, allergy, nutrition and development, social and psychological and impact, we will ask normally. After taking the history, evaluation of the chest pain history. Detailed history and examinations, baseline observations including blood pressure and oxygen saturations, 12-lead ECG, assess the rate, rhythm, signs of myocardial ischemia, ventricular hypertrophy, corrected QT interval, see the ECG interpretation guideline. Chest X-ray, consider if acute severe chest pain associated with fever and cough, post-chest trauma, abnormal any respiratory examination, abnormal cardiovascular examinations. Now management. Management is according to this flowchart, management of the chest pain, that is 3-line: red category, amber category and green category. So if the chest pain is on the red category, what are the criteria? Red category: recent cardiac surgery less than 2 weeks, number 1. Number 2, Marfan syndrome. Number 3, Kawasaki disease with coronary aneurysms. And number 5 is hypercoagulable state. Then what are the measure we take? Abnormal history we find, abnormal examination, abnormal 12-lead ECG we find, then prompt discussion with the either pediatrician with expertise in cardiology or on-call pediatric cardiology center. Now amber category of chest pain, that is chest pain associated with exercise, radiation, palpitations, syncope, known any congenital heart disease, known any acquired heart disease, previous cardiac surgery and family history of sudden death. Then amber category we do find abnormal history, normal examinations, normal 12-lead ECG, and then we discuss with the pediatrician with expertise in cardiology and refer to pediatric cardiology outpatient department, local or tertiary. Then green category of chest pain, that is chest pain, chronic history, local tenderness, worse with breathing or movement, worse with cough or wheeze, worse with eating and posture triggered by anxiety. Then we find normal history, normal examination and normal 12-lead ECG. Then we reassure the patient, give the analgesia, NSAID for costochondritis, PPI for GI, and if recurrent, general pediatric follow-up. What are the differential diagnosis of a chest pain when we take a history? These are cardiac cause, chest cause, musculoskeletal and GIT, psychological and drugs. So cardiac including chest pain are pericarditis, post-pericardiotomy syndrome, pericardial effusion, coronary artery thrombus and bacterial endocarditis, myocardial ischemia, that is congenital heart disease, severe aortic stenosis, severe pulmonary stenosis, pulmonary hypertension, coronary artery disease, that is congenital anomalies, post-Kawasaki, previous cardiac surgery involving coronaries, cardiomyopathy, that is dilated hypertrophy. In chest, we find the chest pain in pleural effusion, pneumothorax, pulmonary embolism, pneumonia, COVID, acute chest syndrome. Musculoskeletal causes of chest pain are costochondritis, trauma and deformities, gastrointestinal, GERD, psychological and drugs. These are the DD of chest pain. According to site of the chest pain, if that is referred shoulder, then that is diaphragmatic inflammations, any perforated viscous, thoracic outlet syndrome and acromial bursitis. In chest, if the pain location, then it is can be acute coronary syndrome, aortic dissection, spontaneous pneumothorax, cocaine toxicity, acute or chronic pulmonary hypertension including pulmonary embolism, pneumonia, acute pericarditis, valvular heart disease, tracheobronchitis, esophageal disorders, costochondritis, intercostal muscle cramps and pectus deformity. Now this is front side, and front side also in shoulder, on the left side shoulder, then it is can be acute coronary syndrome, acute dissection, aortic dissection, acute pericarditis, diaphragmatic inflammation, perforated viscous, acromial bursitis, thoracic outlet syndrome. If go on the left arm, it radiates the chest pain, then it is acute coronary syndrome. If chest pain on the abdomen, then acute coronary syndrome and perforated viscous. Now back of the chest pain. When the chest pain radiates on the back, we are seeing the both shoulder, that is pericarditis, and go on back, that is acute coronary syndrome, aortic dissection and esophageal disorder. So this is all about the chest pain. Thank you.